So my slide is visible, no, and I am audible, I think. Anyone can say?
Yes, sir.
Okay. So I'm going to start with the shoulder USG. Now, when a patient comes to the OPD, first what we do, we make a clinical diagnosis. So in this module, we shall learn about the anatomy of the shoulder, will be followed by the sonoanatomy of the shoulder, and then common pathology, what we see under USG, the common diseases, and then interventions applicable. Okay. So let us see the anatomy overview. Mainly the important, very important anatomical structure here is the rotator cuff and the associated muscles. Of course, while learning the shoulder part, we will see some associated muscles also. But mainly the rotator cuff is the source of all different types of pathologies in shoulder. So if we consider from very deep to superficial, then what we find at the joint level. So in very deep is the joint, and joint is formed by what? Joint is formed by bone, then cartilage, and bone cartilage. That when we are talking about the joint, then there is a joint capsule also. So bone, cartilage, joint capsule. Then above that there are some ligaments. Bone to bone attachment are ligaments. Okay. Then comes muscle level. Muscle layers are tendons and muscles. We can see in two different parts. Hardly there is any disease inside the tendons which come to the pain clinic. Mainly it is I mean, hardly there is any disease in the muscle belly or muscles. It is always in the tendons which comes to the pain clinic or pain physicians. Then other parts are nerve, blood vessel, and in between another important structure is bursa. Whenever there is a tendon, so whenever tendon moves and there is a bone above it or below it, so between tendon and bone always we see a bursa. So there can be just bursitis and we can see fluid in the bursa, but otherwise it is always the bursitis makes most of the time it is reactionary. So mainly the tendon which is affected, and then we see the fluid in the bursa. So here we will first start with the from deep to the superficial part. So here you can see what are the bones here in forming the shoulder joint. So one is humerus, and another is scapula, another here is clavicle, and of course this thoracic cage is also a part of shoulder joint anatomically. So here between the scapula and humerus, this is the so between the scapula and humerus, this is the glenohumeral joint, and this is the actual joint. Okay. When we talk about any shoulder joint pathology, say frozen shoulder type of thing, then we talk about the glenohumeral joint. Okay. So what are other joints? Here there is another joint, acromion and clavicle. Between acromion and clavicle, so this is the acromioclavicular joint, which is also important. Just a minute. দেখ মিউট করে রেখে দে So okay, second joint is acromioclavicular joint. Third joint is here sternoclavicular joint. Why it is also a part of shoulder joint anatomically? Because with many movement, say there is a movement restriction of main glenohumeral joint, so this is compensated by some other joints also, so they are considered together. And then this is scapulothoracic joint. This is a pseudo joint, actually not a joint, but this is also a part of shoulder joint. But here, and for understanding the musculoskeletal USG of the shoulder, we will remain concentrated on these two joints. One is acromioclavicular and one is glenohumeral joints. That's it. Now, so you can see under X-ray how it looks. Okay, so you can see that, okay, this is the thoracic cage, this is coracoid process, this is coracoid process, and this is acromion. Okay, so and you can understand this is clavicle. So let us see, and here one important structure is glenoid labrum. So this is also at the joint level. When we have talked about the bones, so this is also a very deep structure. So what happens is the head of humerus is much bigger, and the glenoid cavity, this is not that cup type which can hold the head of humerus. So that depth is made by the glenoid labrum. So this is a fibrocartilage. There are two types of cartilages in our body. One is fibrocartilage, one is hyaline cartilage. We know under ultrasound how they look. So hyaline cartilage will be always a black line, anechoic structure like water or like blood. It is anechoic structure. But when we talk about the fibrocartilage, that is hyperechoic, white fibrous structure. And then so after that the joint, you have understood, the joint is covered by glenohumeral joint capsule. Okay, here one important thing is, see the capsule here. This capsule has an extension around a structure. So this is actually the biceps tendon, long head of biceps has two head, one is short head, one is long head. This is the long head, and short head actually comes and attaches to the coracoid process. So this capsule has an extension around the long head of the biceps up to a certain distance. Okay, so you can understand, if there is a fluid inside the capsule, some fluid will trek down, and you can see that some fluid is there around the biceps, long head of biceps tendon. Okay, now let us see the muscles. Okay, so these are the rotator cuff muscles inside from. Okay, I just show you in some other way. When we are talking about the muscles, we will start with the anatomy. So here, this is a 3D anatomy. Just see. So for remembering purpose, the muscles we can divide into one superficial or layer 1 group, layer 1, and then deep group, that is layer 2. So first you see this muscle is nothing but trapezius. Okay. Okay, so this muscle is nothing but trapezius. Now you see the attachment of trapezius or borders of trapezius. Here it is the clavicle. It is the clavicle bone which is the border of the trapezius. And this side, what is this? This is the spine of scapula. So in a normal on a volunteer, when you are starting for your ultrasound, then you must remember this thing, that between clavicle and spinous process of scapula, all the muscle first layer, most superficial, that has to be trapezius. Let me hide it. Second muscle, so whatever the margin of the trapezius, if we medially it was the trapezius, laterally what we see, it is completely covered by deltoid. Deltoid has three slips. Okay, one is anterior head, three heads or three slips: anterior slip, lateral, this middle slip, and this is the posterior slip. Okay, three heads or three slips are there. So this is the deltoid part. But remember, this muscle is also layer 1, most superficial, under skin, subcutaneous tissue. So if you put a probe, the ultrasound probe between this spinous process of spine of scapula and clavicle, you will see the most superficial layer of trapezius. If you put your probe in this side, or just below the clavicle, or just below the spinous process of scapula, then you will see the most superficial layer should be deltoid. Okay, so I hide this whole deltoid layer. So another superficial muscle is there, which is not actually a part of this one, your not a part of shoulder ultrasound. But sometimes while seeing the ultrasound of shoulder, when we come down, then we see this pectoralis major tendon also. Okay, but this is not a part of shoulder ultrasound. So what are the other muscles? Now, second group of muscle. Okay, see carefully. Second group of muscle, one muscle is this one and one muscle is this one. So this is the most important muscle, that is supraspinatus muscle. You see, this is the supraspinatus muscle. So this is just under the trapezius in this area when it has not crossed the acromion. But when we will see lateral to the acromion, this is under the deltoid. Okay, so this is second layer. So lateral to the acromion, this part is nothing but tendon. It is only tendon. But in this area, it is the muscle belly. So if we put a probe here, we will see two muscles. So one is trapezius, and just below there, layer 2 will be supraspinatus. But here, if we put the probe, then what we will see? First, we will see the deltoid, and second layer, we will see supraspinatus tendon, not muscle. Myotendinous junction is mostly under the bone. But we can of course see that. How we can see that? If we do some movement of the humeral head, say some movement we are doing, so that this tendon, we are just stretching it, we are pulling it laterally, then myotendinous junction will come out. Okay, so everywhere I am not using the exact medical term, just I am trying to make you understand the phenomena, so that you don't have to memorize anything. There is no question of just memorizing. So you can understand that some movement has to be done so that this tendon can be pulled out. Okay, now comes second tendon, second muscle. Okay, supraspinatus we have understood. This is one rotator cuff muscle. Remember, rotator cuff means four muscles. Four muscles together form the rotator cuff. Now, second muscles that is inferior to the spine of the scapula. Okay, this is the spine of the scapula. So inferior to the spine of the scapula. So here what we are getting? So here we are getting the infraspinatus muscle, and this is also coming and attaching to the greater trochanter of the humerus, greater tuberosity of the humerus. So supraspinatus and infraspinatus. So infraspinatus here is also, you can see that some part, a part is, it is the deltoid. Mainly when you see in the lateral side, above that it is the deltoid, and below that this is the second muscle, which is the infraspinatus muscle. Okay, so this is a second layer muscle what we are talking about. Then third rotator cuff muscle is the teres minor muscle. Okay, this is also another rotator cuff muscle. So three we have understood. Where is the fourth muscle then? So you can see clearly, fourth muscle is this one. This is called subscapularis. This is called subscapularis. If I make it a bit bigger, then maybe okay, so this one is subscapularis. You can understand that it starts from the subscapular fossa, and then it comes and joins in the humerus, that is the lesser tuberosity. Now this part in this picture, it is not very great, but you can understand that here, where the biceps tendon is entering inside the joint, this area, there should be a groove, then bicipital groove. So lateral to that bicipital groove, there is greater tuberosity, and medial to the bicipital groove, that is lesser tuberosity. I will show in picture, but in this anatomy software it is not very clear, but medially this is the lesser tuberosity and this is the greater tuberosity. So you can see what attaches to which tuberosity. So subscapularis muscle attaches to lesser tuberosity, but supraspinatus, infraspinatus and teres minor, these three muscle comes and joins in the greater tuberosity. Okay, so lateral side greater tuberosity, and medial side this is the lesser tuberosity. Okay, so this is the so if we remove these muscles, so this is infraspinatus, this is teres minor. Okay, Here there is another muscle which is a related muscle. As I told you, there are some related muscles. So this muscle is nothing but teres major muscle. Okay. So this is again going and coming to the forward side, front side of the humerus, in the shaft of humerus. Okay, but this is just related. While we are doing the ultrasound of shoulder, we may see for some reason the teres major also. So what another muscle is very much important here. We have talked about the 4 muscles of rotator cuff, but when we are seeing this area, then we see this biceps tendon also. Okay, so this is the biceps tendon, and if we remove everything, then we will see so if we remove everything, then we will see where the bicep tendon attaches. So this is going inside the joint and to the glenoidal labrum. So this is a part of biceps tendon is forming a part of the capsule of the joint. It is going inside the capsule. So earlier picture I showed you that just around the biceps tendon, there is extension of capsule. So this biceps, if you give some injection or anything just around the biceps tendon, then it will go inside the joint. And likewise, if there is a effusion in the joint, then the fluid will be found around the biceps tendon. So we have importance of this anatomical information. Okay. So just here you see one thing, that this supraspinatus tendon, which is the major source of all type of rotator cuff tendinopathy, many types of tendinopathy, not all, but then this is the major of great importance. So here you see that if you see the supraspinatus tendon up to this much, you can see, and after that you will be on the bone acromion. This is the acromion, and then you will see the tendon here. So there is a possibility that when there is movement, this tendon and bone can rub each other. And so, I mean, there is always a bursa, and that we call subacromial subdeltoid bursa. Now, why the name is subacromial and subdeltoid bursa? Because it is partly under the acromion bone and partly under the deltoid. So in this area where the bone is not there, you can understand this is the second layer. So this is the tendon, and what was the first layer? First layer was the deltoid. So this bursa, which is a big bursa, so this name is subacromial subdeltoid bursa because it is under both the structures. Okay, so with this much, okay, so just okay, so this much is enough for 3D anatomy part. Let us so here, so we were there in this slide. So you can see subscapularis, which is coming from the anterior side. These are rotator cuff muscles. And actually, why the name rotator cuff? Because it is like a cuff. It is covering the whole joint. Okay. So there is only a small gap in the front, but otherwise it is covering the whole joint. So subscapularis here, then comes supraspinatus. Then this was the supraspinatus, this is infraspinatus, this is teres minor. This is the superficial layer. So as I told you, just below the clavicle or below the spine of scapula, you can see this is the deltoid muscle. You can see that biceps tendon, short axis actually goes to the coracoid process and long axis goes to the actually glenoidal labrum. It is not shown here. Okay, it is shown here. So like that, it is going to the glenoidal labrum. Here, one important thing, you can see that this long head of biceps is going through a groove. So this groove is called bicipital groove. Okay. And lateral to the bicipital groove, this is the greater tuberosity. Medial, it is the lesser tuberosity. And as I told, muscle, subscapularis muscle will start in this area, subscapular fossa, and it will come up to this much lesser tuberosity, whereas other muscles will come from backward or upward, and supraspinatus, infraspinatus, teres minor, and will reach up to this much. So this is the greater tuberosity. Of course, not this much. This in these areas. See, these areas are greater tuberosity area. These are related muscle, as I said, in the front of our arm. So this is the biceps. While seeing, we have seen the long head of biceps. Below that, there will be brachialis, which doesn't come up to the shoulder, so we don't have to see. But below that, there is another muscle, so that is called coracobrachialis. So this is also coming up to the coracoid process. And sometimes while doing ultrasound of shoulder, we see the coracobrachialis muscle also, because everywhere where there is a tendon formation and joining at the bone, so there is a chance of tendinitis. And this is, I told you, teres major. So major goes in the front side, okay, like subscapularis muscle going in the front side, I mean tendon. Anyway, so this part, another related muscle is trapezius. So you can see this is the trapezius muscle, okay. Yeah, this is the pectoralis major and this is the trapezius muscle. So these are also related muscles. Here, one important thing, just for information, nerve supply, you just remember supraspinatus and infraspinatus is supplied by suprascapular nerve. So this is important. Supraspinatus, infraspinatus is supplied by suprascapular nerve, whereas teres minor and deltoid is supplied by axillary nerve. Okay, subscapular nerve is supplied to teres major and subscapularis. So let us see the bursa. So here there are multiple bursas. As I told you, whenever there is a tendon formation, there is a tendon and which there is a chance of rubbing with the bone. So in between those two things, there is a bursa. So here it is the subacromial subdeltoid bursa. So what are the structures between which it protects? So one is acromial bone and one is supraspinous tendon. So supraspinous, between supraspinous tendon and acromial bone, it is subacromial subdeltoid bursa. So which is most important actually, because clinically we find this bursitis much common. Now there is another bursa, subcoracoid bursa, because subscapularis tendon comes from the subscapular fossa, and here the tendon is already formed. And whenever you are rotating your hand, internal rotation and external rotation, there is a chance of rubbing of the tendon of subscapularis with the coracoid process. So between them, these two, there is another bursa, that is subcoracoid bursa. And there are multiple other bursas. So these two are most important here. Nerves, as I told you, you already know the suprascapular nerve supplies supraspinatus and infraspinatus. But how they are formed? So we know the brachial plexus formation, and it has their root trunk division cord, and then terminal branches comes. So from the trunk part, this is the suprascapular nerve is formed, and this suprascapular nerve we can find it in the suprascapular fossa. In the supraspinatus fossa, we can find this suprascapular fossa, and so with the artery and nerve remains together, and then it comes down and it is found in the spinoglenoid fossa. There is two fossas, okay, one is spinoglenoid fossa, one is suprascapular fossa. So suprascapular nerve can be caught in both the can be targeted in both the areas, but remember, when you are targeting at the supraspinatus fossa, then it is a motor nerve. But when you are actually targeting in the spinoglenoid area, then it is only the articular nerves, and motor part is already motor branches are given to the muscles. So this is the sensory, only the sensory supply. So most of the time, for denervating purpose of the joint, we want this nerve, this part only, spinoglenoid area. And if you, of course, if there is a problem in the supraspinatus fossa where there is a motor nerve, then we will not damage that. For other procedures, we can target there also. Now demonstration on volunteers. We will start demonstration, but before that, just see two important thing. One is position of the patient or position of the volunteer, and one is probe selection. So what is the importance of position? So as I told you that we can take we can do different positioning of our hand so that the head of the scapula humerus moves. Head of the humerus moves. And why we want that? Because ultimately supraspinatus, infraspinatus, teres minor, all the three muscle tendons are joining in the head of humerus. So we should be able to rotate the humerus in such a way so the tendons which are there under the bones, they should come out. Okay, so either we will go for internal rotation or external rotation, which I will show you on the volunteer, but then which I will show you, but then just see. So this is neutral position. This we start with for seeing biceps tendon. Okay, and this is called cross position. Cross position. This is modified cross position. And nowadays this position doesn't have a name as such, but this is just 20-degree extension of the 20 to 30-degree extension of the shoulder joint. So this is the position which is mostly used nowadays. We do not need to go for cross and modified cross position, because these two positions are possible in volunteers only, not in the patients, because patients have too much pain. So we go with this position where actually it serves the purpose of all other positions. And we will do some dynamic movements also to see the different tendons. Now comes probe. So probe selection for shoulder ultrasound, it is always the linear probe. Frequencies will change in most of the areas. If it is some superficial structure, we want to see some very small structure, then we will go with the high frequency. Otherwise, in between frequencies, say 12, 13, 14 frequency is enough. Okay, so this is probe selection. Another thing, USG, while you are performing the USG, so USG screen, patient and examiner should form one line. This is actually important for doing every procedure also. You can, of course, you can use two monitors. Two monitors will give you much flexibility in this way, because one monitor you will see whenever you are doing an ultrasound from back of the volunteer, then volunteer or patient, whatever. So you have to your monitor should be in front of you so that you can see that what you are seeing. So for intervention purpose, that is must. But if you have two monitor, then of course the main ultrasound machine you can keep just on your right side or left side, and the another monitor you can keep in front of your eyes so that you can see that monitor. So at least the monitor which you want to which you are seeing continuously, that should be in your front. Okay, so demonstration, remember few small universal law of doing ultrasound of many areas. So this applies to the shoulder area also. First, identify the bony contour. Uh, many areas, bone tells us. Bone is our enemy also and friend also. Why it is enemy? Because the ultrasound beam doesn't pass under the bone, so we can through the bone, so we cannot see what is there under the bone. That's why enemy. But why it is friend? Because small change of bony contour tells us that where actually our probe is, what we are seeing. So always try to identify the bony contour. Then identify the layers in ultrasound, which layer you are seeing, just try to identify. Then identify the tendon formation. Tendon formation means from the muscle belly, tendon is not that it is like a hinge joint that suddenly tendon started. Tendon formation starts from the through the bone, muscle belly. So small tendon is formed, and then it becomes complete tendon. So you will always see a myotendinous junction, and there always the whole tendon should be seen, and up to the myotendinous junction should be evaluated. This much should be evaluated. Then length and breadth of the structure, as I told, when you are seeing a tendon, so with ultrasound what we are seeing a cross section. So you see the supraspinatus muscle in a cross section, and tear is not there, just above it or just below it. So there is every possibility that you can miss that. So you can see whole breadth of that muscle or whole length of that tendon. So length and breadth full. Then comes look for the vessels. So this is mainly for interventions, that whenever you are doing some intervention, you should not puncture the vessel or should not puncture any drug inside the vessel. Identify congenital variation. It is always even in shoulder ultrasound, we always see that there is some variation in say in every volunteer. There is some different variation, small variation, but it can be small variation or it can be big variation, but then variation is very common and it can be. So you don't think that it is a disease. It is not matching the what we see every day, so it is a disease. So some variation may be there. Identify the abnormality, compare with the opposite side. So if you have some, in ultrasound most of the time you expect something, and this is sometimes happens that you feel that there must be something, it is not very not normal, but when you see the opposite side, when there is no complaint, nothing, you see the same thing in the opposite side. So you understand that okay, this is not abnormal, this is normal for him. So identify the abnormality by comparing the opposite side. Then comes dynamic examination. So dynamic examination, whenever required, you go for dynamic examination and see the whole structure. So this is a positive point of ultrasound, which we do not get in any other modality. Okay, which is X-ray based or MRI. So expect a structure. This is also a rule. Always you should know the anatomy and you expect a structure there, then only you will see very easily. Otherwise just by seeing ultrasound, I cannot say, if I don't know the anatomy of that area, I cannot just imagine the structure. Understand the function of the tendon. So clinical test and dynamic examination. Here uh, tendon, what it does, so you always should understand the concept. Okay, and this is both important for clinical test and dynamic examination. So what is tendon? Tendon is joining the muscle to the bone, and what will happen, what movement it will do. So it is when the tendon, when the muscle contracts, so you can understand the whole length of the muscle plus tendon, the total myotendinous unit, that will get shortened, and that will produce the movement of the joint, either it is abduction, adduction, or whatever it is. So for clinical test also, in dynamic examination, of course it is not the muscle which is contracting. We are sometimes going opposite to the tendon, tendon action, so that we can increase the tendon length. Okay, and so more of the tendon we can see. Tendon is not contracted, we are doing passive movement. And when it is a clinical test, then it can be active or passive. When the patient contracts, so it is the active movement of the tendon, and when we are stretching the tendon, then we go for the opposite movement and we do passive movement for stretching that, for giving more pressure to that tendon area. Okay, so adjust, and while just for ultrasound purpose, ultrasound machine, so only few things are important. One is gain, depth, frequency and focus. Nowadays, focus is also not there in many machines, it is automatic, but you should have the control of these three things. So adjust gain for making it bright or dark. One type of gain is TGC, you know, and depth. So whatever depth is needed, so you keep your target structure or structure of your interest in the middle part of the screen. Okay, then comes frequency. So nowadays probes have multiple frequencies. So when you are seeing a deep structure, go to lower frequency. When you are seeing a superficial structure, go for higher frequencies. And focus, you have to manage it, you have to target it at the same depth. And no globally accepted fixed sequence. If you start from seeing the biceps tendon and then go to the supraspinatus, infraspinatus, it's okay. If you start from infraspinatus tendon and go to the supraspinatus biceps like that, then also it's okay. And we can start from supraspinatus also. So demonstration, first we will see the biceps tendon, then we will see all the rotator cuff tendons, then we will see SASD bursa, and then we can see glenohumeral joint and AC joint. Okay, then we will discuss about all the different pathologies. So let's see. তুই বস, আমি ঠিক করছি table. Okay, if anyone have any question, please ask me. Okay, right sir, না খোলার দরকার নেই, তোকে ভিজতে ভিজতে দেবো। আচ্ছা ঠিক আছে, হবে হবে, তুই আর ওদিকে আয়। You can ask me if there is any question. So okay, you are not answering, so let me ask you one question. What is the location of SASD bursa? Anyone can say. From skin, subcutaneous tissue, and then what we will see? First layer, so most superficial layer, what layer we will see, and what will be the second layer? I am audible, no? Nobody is telling anything, so I am audible.
Yes.
Okay. So
below deltoid will be the yes sir.
no, nobody can tell where is the SASD bursa. So first, পিছনে দাঁড়া, এদিকে একটু ঘুর। Because as I told you, we have to expect something. What we expect, that only we can see. I mean, in ultrasound,
Deltoid.
What?
It is below acromion, subacromion, subdeltoid. Below acromion, below deltoid.
Yeah, but then I'm saying that under ultrasound, after skin, subcutaneous tissue, which structure we will see?
You see deltoid, and below deltoid you
Yes.
see the
Then bursa, and then below that?
supraspinatus tendon.
Yes, supraspinatus tendon. Okay, then. Okay, so we are starting. So see, you can see the patient's, not patient, volunteer's position. So for seeing the deltoid muscle, we can not biceps tendon. First, we are seeing the biceps tendon. So just see, for seeing the bicep, we are starting at the bicipital groove and seeing the biceps tendon. This neutral position is all right. And when we will go to see the supraspinatus, infraspinatus, teresminor, all these things, then we will just make a modified technique like that. Okay, just this much is enough, nothing else, mainly the supraspinatus. So what this movement will do, this movement will actually rotate the this extension movement, the head of the humerus, it rotates like this. It rotates like this. So the tendon which is coming from here, supraspinatus muscle is here.
Volunteer is not visible, sir.
Yeah, I cannot visible the ultrasound, the patient.
Is it? Okay. Now,
Yes.
okay, I forgot to share. Okay, anyway. So, okay. So here, as I told you, so this is this we are starting from the bicipital groove. So long head of biceps. We know this is biceps muscle, and from here the tendon is coming. Tendon is coming through the bicipital groove, and then it is going inside the joint, inside the glenohumeral joint. Okay, and since head of the humerus is here only inside, so here some few things we can palpate. We can palpate the clavicle. He has become very fat, but still this is the clavicle. So okay, this is clavicle, and this is the spinous process, spine of scapula. So this is the spine of scapula. Here this is the acromion. So whatever we see, this is the acromion. Okay, this is the acromion, and if we just start from clavicle, we do like this, and then at some point we find, so this is the area which is the acromioclavicular joint. This is the acromion. This is total part is acromion. So this is edge of acromion, and this is the acromioclavicular joint. Okay, this is the clavicle. So this much we can understand just by palpating. So now we are starting with the biceps tendon. So this neutral position of the volunteer is all right. So okay, let me start with this, then I will tell you. So here, what we are seeing here is the bicipital groove. If we go down, then we see it is the bone of humerus. Okay, it is completely humeral bone. Then we come up gradually. I am coming up. I am holding the probe in a short axis view. Okay, in a short axis view, left side of your screen is the medial side of the volunteer. Okay, just this medial side of the volunteer is left side, and right side of your screen is the lateral side. So here what we are seeing, it is the bicipital groove. Just as I told you that first you should see the bony contour. So that is also important. Please go, please. So this is note it. Okay, so here you see this is the bicipital groove. Okay, this is the bicipital groove, and as I told you that this left side is medial side. Okay, and right side is the lateral side. Right side is lateral side. So what we can see? So right side, since it is lateral side, it has to be the greater trochanteric tuberosity side, and it has to be the lesser tuberosity side. Okay, and if this is the groove, this is the bicipital groove, then what should be there lying? So this is nothing but the long head of biceps tendon in a short axis view. Okay, so here one important thing, tendon is always hyperechoic, isn't it? It should be white color, but it is black here. So what it can be? So as I told you that immediately you do not think that there is some disease. So it can be a simple anisotropy. If I just tilt my probe, then this tendon may become black to white. Okay, so this is the tendon. Okay,
Susu kami, sir. That's what.
so Yeah, so this tendon has become white. See, this tendon has become white. So this is the long head of biceps. If I go down here also, this is in the bicipital groove, but if I tilt, this tendon becomes white. So this is a phenomena which is shown by the biceps tendon very commonly, which due to anisotropy. So now this tendon is white. Can you see clearly? Anyone has any I mean, like, any confusion that this is the biceps tendon we are seeing in the bicipital groove? By seeing the this one bony contour, we can understand that this is a groove. Okay. Okay. Now we will see this same tendon in a long axis view. So this is a bicep, this is the biceps tendon in a long axis view. Just a minute. ওই হাতে ধর, তুই হাতটা নড়াবি না। Okay, so this is a biceps tendon in a long axis view. Here the left side is cranial and right side is caudal. Okay, right side is caudal. So what is this? This is the bony periosteum margin of the bicipital groove area. Bicipital groove area. Okay, so say here I have put my proof. So this is the bicipital groove area. So where is the tendon? So this is the tendon. So this black part, this black thing is the tendon. And as I told you that this is actually not black. You see, this part is white. So this part is not showing anisotropy. That's why it is white. Other parts are black due to anisotropy. As soon as because the beam are coming like this and they are reflected like this, it are not going reaching to the probe again. That's why this is anisotropy. So this is the long axis of biceps tendon. Okay, long head of biceps. Now let us see that how far we can see the long head of biceps tendon. Of course, we will not be able to see the complete length, but we can see up to some amount. So this is the long head of biceps tendon. Okay. So if I go inside the joint, you can see up to this much. Up to this much, we can see that it is coming up to the inside the joint, up to this much, say. Okay, up to this much. No, not this one. Okay. So okay, this is the, you can see that this is the complete tendon. This is the long head of biceps tendon. So as I told you that both side, there is one side is the greater tuberosity, one is the lesser tuberosity. So if when I am showing you the groove, if I come medially or laterally, there should be the bony contour should tell you that you are not in the groove and you are on the tuberosity. So let's see if that is true or not. So this is the biceps tendon area. Okay, this is the groove, this is the complete groove area. Now I am going laterally so that I can see the greater tuberosity, and you see the bony contour, it has become much bigger. Okay, much superficial. So this is the greater tuberosity, this is bony contour of greater tuberosity. As I go a bit medial, I see the bony bicipital groove again, and I see the whole tendon, long head of biceps. Now I am going a bit more medially, so that I can again I will see a hill type of area, and that is the lesser tuberosity. So this is the lesser tuberosity area. Okay, so this is the lesser tuberosity. This is the bicipital groove. This is the greater tuberosity. Bicipital groove. and this is the lesser
Sir,
tuberosity.
can you mark and show with the markers, sir?
Okay, okay, okay. I thought this is very easy to understand. Okay, just freeze, freeze. So, see, I am putting the probe in this way, okay, in this long axis. Then I am coming laterally means I am going here and in the same axis. And then if I go medially, I am going medially in the same axis. Here, the head of humerus, say this is the head of humerus like this. So here there is a groove. So if I go medially, I have to see the lesser tuberosity, and if I come here in the laterally, I will see the greater tuberosity. So the same thing when here, this is the cranial side, this is the cranial side means here, and this is the caudal side. So this part is the caudal side. So when I'm doing like this in the medially, then this picture comes. Here, this is the lesser tuberosity. This is the lesser tuberosity. So when I will come medially, you will see that this tuberosity is not there. This tube, when I will come laterally a bit, this tuberosity will not be there. So this is lesser tuberosity, and then there will be a straight line area, which is the area for biceps tendon, which is the groove area. And then again I am coming laterally, then I will see again another heel type of area, and that will be the greater tuberosity. Okay. So I again show you. Okay. So this is the lesser tuberosity. See, this is the medially, it is lesser tuberosity. This is the bony contour of the lesser tuberosity. Now I am coming a bit laterally. So this tuberosity is going, and we can see the so this is the lesser tuberosity. We are coming medially, and we can see the bicipital groove. So this is the bicipital groove and tendon. Okay. So bony contour, you can see it is a much straighter, much straight, and we can see the above bicipital tendon also. Can you see or not? There is confusion.
Yes, yes,
Okay.
yes, sir.
Please, let's see. There's no confusion. Okay. So this is the bony contour. This is the bony contour. Okay. And tendon is this fibrous tendon. This fibrous tendon. We are seeing in a long axis. Okay. In short axis, it will be like this one small dot, not dot, I mean ball type of thing. But then in long axis, we will have this type of tendon. And as soon as I come a bit more laterally, I see the greater tuberosity. That's it. So this is the biceps tendon, and as I come more laterally, so this is the greater tuberosity. Okay. So this area, this big hill type of bony contour of the greater tuberosity, and here of course we will not see the tendon. Okay. So this is the first part, biceps tendon, and this is long axis and short axis. Already I told you. So this is the both tuberosities. Left side is lesser tuberosity, right side is greater tuberosity. Okay. Left side looks a bit sometimes bigger because it is conical, but area wise greater tuberosity is much bigger. Okay. So and between them this groove is there, and you can see biceps tendon sometimes become white and sometimes becomes black. Sometimes it can become black also. This is black and this is white. This is black, this is white. Okay, so mainly it is basically a hyperechoic structure. It is white. So now let us see. So now let us start with the rotator cuff tendons. Okay, so why we have seen the biceps tendons in this way? Because as we needed to identify which is the greater tuberosity and which one was the lesser tuberosity. And we know that now when you know that okay, this one is lesser tuberosity and greater tuberosity. So you know at the lesser tuberosity one muscle becomes tendon and joints. What is that? that is the subscapularis tendon. So this is the subscapularis tendon, and in greater tuberosity also there is one muscle comes, so that will be the supraspinatus, that I will show you. So first thing, let us now go from lesser tuberosity to subscapularis muscle. Okay, so subscapularis which should come, so here in the anterior side it is the from subscapular fossa it is coming, and it will be joining like this. Okay, subscapular fossa to coming to the lesser tuberosity. Now we will again keep in the neutral position to see. Okay, জল হয়ে গেছে সব। Okay. So we can see lesser tuberosity. Now left side is medial side. As soon as we one tendon, this part freeze. Okay. So you have understood that we have gone to, this is a short axis. Okay, this is the short axis and we are seeing a tendon here. So where is the tendon? So this, we have just moved from this side to this side. Our probe is in the short axis. Our probe was in the short axis and I just moved a bit in the medial side. So what we are seeing, so this is medial side. Remember, this is medial side and this is lateral side. So in medial side, this is bicipital groove. This is bicipital groove, and here it should be the biceps tendon. And this is the tendon. This is the I can show. So this is the actually the tendon area. Okay, so there has to be some muscle in this area also, but this has become tendon and it is coming and joining to the lesser tuberosity. This is the lesser tuberosity in the medial side. So try to imagine that what I am showing you, try to imagine from the anatomy part. From the in the anatomy part, try to imagine. Okay, shoot. Okay. So here, this is the biceps tendon you can see, and bicipital groove also you can see. So now I am going in the medial side. So what you can see, so there is one tendon. So this tendon is subscapularis tendon. Okay, now how you can remain a bit confused that okay, this is tendon or not. In subscapularis tendon, any tendon, there is a bird peak appearance. So this is subscapularis tendon, and we want to see a bit more of the tendon. Then what we can do, we have to rotate the head of humerus in this way. So, I mean, if we just do the external rotation of the hand, so you can see that this tendon is moving. Okay, so this tendon is moving. Okay, so we will rotate it external in the external side, so that we can see the whole tendon. You see the whole tendon. So this is the tendon of subscapularis. Yeah, this is the whole tendon of subscapularis. And if we go more medially, you can see some areas that is black and white areas. So these areas are nothing but the myotendinous junctions. Okay, just freeze. Okay, sure. So this much, these areas are actually the tendon part, main tendon part. Okay, main tendon part, subscapularis tendon, subscapularis tendon. So here, subscapularis tendon, but then here you can see this part is white, black, and then white, like that. Okay, because this side is muscle, this side is muscle. We cannot see more muscle here because here there is a coracoid bone. There is a bone is there, and other structures are also there. So we cannot, and it is too deep, so we cannot see any muscle here. Thoracic cage will start, we will not be able to see. So our purpose is served. So from tendon, this tendon part, this is the myotendinous junction, and then comes muscle. So up to the myotendinous junction is our target, and we will see the area where it joins in the lesser tuberosity. Okay, so from there we will start and we will come more medially. চোখ খুলে রাখতে একদম ঘুমাবি। Okay. So we start again from here. So this is the bicipital groove area. Okay. So this is the bicipital groove area, and then I am going more medially. I am going more medially. First, I have assessed the tendon. So here, just the bird peak appearance, which is coming and joining at the lesser tuberosity. This much area I have already assessed. So in subscapularis tendon, you cannot assess the whole tendon completely together. Now only now in this picture, I will assess only this much area. Okay, so after that I will assess this much. Okay, now only this much. So this is the subscapularis tendon which is joining at the lesser tuberosity. Okay, and this is the lesser tuberosity area. And what I am assessing, I am just assessing the hyperechoic white color and the fibrillar structure, hyperechoic fibrillar structure of a normal tendon. And also I am assessing the bony periosteum if there is some I mean there is some what should I say, irregularities. There is some irregular margins, so it is not there. So you can see medially. Now I will go more medially and I will see the whole tendon. Of course, with dynamic movement I can see much more easily the whole tendon. So you can see the actually whole tendon is white, and this medial side, which I told you, please see for myotendinous junction, white black, white black. So this is the whole tendon. Okay, so this is the normal tendon. This is the normal tendon, normal architecture. This is the fibrillar structure of the tendon, and there is no bony irregularities. Okay, so this is the way to see the subscapularis tendon by dynamic movement. And when if there would have been a calcification, tear or anything, so as soon as you move, so there will be pain. So you all have understood, no? Any confusion? Two structures I have shown. Is there any confusion? Now I am going to the third structure. So that is in rotator cuff, from the front side, it is the subscapularis tendon. Which is important for us is the insertion. So it is the subscapularis muscle and tendon. So mainly the insertion, tendon and myotendinous up to the myotendinous junction, which is important for us. Okay. Now it is the supraspinatus. So let us see the now supraspinatus muscle. Here the in last subscapularis, while seeing the subscapularis, patient volunteer was like in this neutral position, and I did internal rotation. This is internal rotation, this is external rotation. So I did this external rotation mainly to see the whole tendon. Head comes out, rotates like this and the tendon also comes out from beneath the bone. But now that muscle, supraspinatus muscle, will go like this, and from here it will come out. It is the acromion area. So this is the acromion margin. So it will come out like this. So I will do this type of movement. Okay, so that this tendon is pulled out and we see more tendon which is coming and joining in the greater tuberosity. Okay. So let us first see the muscle belly. Muscle belly. Okay, okay. So here what we are seeing here. there are two muscle. There are two muscle. You can see very nicely. So someone tell me what are these two muscles? The area which I am holding, it is the above the spine of the scapula. Above the spine of the scapula. So and
Supraspinatus.
yes, so there are two muscles. The above muscle, that is the
Trapezius.
deltoid,
Supraspinatus.
trapezius, and below that is the supraspinatus. Okay, so you can see the first muscle layer, which is we are seeing. Okay, freeze করতে। Okay, so first muscle layer, it is a bit more white. So this muscle layer, so this muscle layer is trapezius, and this is the bony margin of scapula. Bony margin of scapula. Between them, this is the supraspinatus. Okay. Now, someone may say that there is another, this white line is there. Why it is not another muscle? So, remember, this is the tendon formation. This is the central tendon formation of supraspinatus. This will only become the actual tendon and which will come out here, come out under the acromion when these muscles are not there. This part, this white is skin, you understand, and this is the subcutaneous tissue. Below that, this black and white small lines, this is the subcutaneous tissue. So skin, subcutaneous tissue, trapezius, supraspinatus, and this side is medial side. This side is medial side and this side is lateral side. So if I go more laterally, means I am coming in this way more. So what I will find? I will find a bone here. That bone is acromion, and then I go more laterally, then I will find the tendon of supraspinatus. So with this concept, I am starting. So again, so with this one, so you see trapezius, and then this is the supraspinatus, and this is the central tendon. Okay, this is the central tendon. So as I am going laterally, I am gradually going laterally. So what is this? This big white line which is casting the shadow. So that is the, this is due to, this is bone. As it is bone, so we cannot see anything behind that, and this muscle with this tendon is going below the bone. So this is the subacromial area. This is the acromial bone. So if I go more laterally, then what I will find? So I will find the tendon of supraspinatus, please. So here, as you can understand, that this part, so this is the acromion, and this is the humerus, but it is two parts. Okay, so this is the greater tuberosity, and this is actually the head. This part is neck. So this acromion, greater tuberosity, acromion, and below acromion, this is the supraspinous tendon, and which is giving a Bart peak appearance. This is the Bart peak appearance. Okay, so here, as it is the whole tendon, it is always white. It is white, and it is the fibrous structure. It is the white color. So if I do some more movement, some more dynamic movement, I can bring some more part of the tendon from below the acromion bone, which is hidden here. I can pull it out. Okay, and remember, this is deltoid. Okay, this is deltoid. So first layer of muscles, second layer of muscle. So now I will try to pull out more of so pull out more of the supraspinatus tendon. So you see how much tendon is out now. Okay, a lot of tendon is out. So this is the please put okay. So now we have pulled out up to that much where we can see there is a black part and then white part. This is white part, white, black, white. So this part we can see. That means tendon is over here. So this is myotendinous junction. And rest of the part, this is the tendon. Okay, this is the bird peak appearance. That is the typical description, bird peak appearance of supraspinatus tendon. Okay, and now so mainly all the abnormalities are found in this part only. This is deltoid and this is supraspinatus tendon. This is greater tuberosity. This is head of humerus. Let's see if we can find some more structures or not. So, now you see the dynamic movement. If it goes in the neutral position, so this part becomes much smaller. Okay, so now this part has become much smaller. Again, when it comes back, then only now when he moves, it becomes bigger tendon, much bigger tendon. Okay, and you can see we have already seen the myotendinous junction. Our again position. So he is going back to the original position and you can see the movement. Okay, okay. Our video I think আগের মতো দাঁড়াও না সে লাগুক ধরো okay. Sometimes these things are not clear. And please. Okay. So more we go towards the head, we are seeing the whole supraspinatus tendon, and more we go towards the head, we see the cartilage part also. So this is the articular cartilage. This is the articular cartilage. And this cartilage can be in the head only, not in the neck or greater tuberosity. So this is the articular cartilage area. Okay. Okay, so now what while showing the muscles only, I tell you that there is another structure which we have already talked about, that is SASD bursa. So where we should find it? We should find it between the supraspinatus tendon and deltoid muscle or acromion. So this is the acromion we are seeing and this is the deltoid we are seeing, and first layer and this is second layer. So between the first layer and second layer we must be seeing one SASD bursa. Now since he is a volunteer and there is no I mean he doesn't have any fluid in the bursa, so we will not be able to see the bursa in a very good way, but we will be able to understand the area which is a potential space and we should be seeing for any fluid collection. Depth. I reduce the depth here. So here only that part which is the supraspinatus and deltoid, this tendon part here, if we see no. Actually, when there is no fluid, it is very difficult to show. Okay, let me bring him in very neutral position. Okay, freeze. It is not very clean, but still where we should see. So between 1 and 2 layer, this white color you will see. Okay, so these are loose areolar tissues, and between them there is a black line. Okay, so this black line is not very well seen here, but when I will again show and you try to perceive a black line here, so this is nothing but the bursa. So between these two layer, first see the big white line, and just between the white line there is a black line, and our intervention should be in this black line, so that you inject in one part and the whole part is the inflated. I will show the videos, of course. So again, I'm showing you the area. Try to understand. Okay, that whether no, it is not clearly seen. So here in the white line, between the white line there is a black line. You see, between the white line there is a stop. So this one is a bit better seen. So this is also whole part is white line, but in between them you can see this is a black line. So only this part of bursa is seen. Okay, so this is the subacromial subdeltoid bursa. Okay, try to perceive. Okay, so this is the most important structure. Okay, shoot. Shoot now. So again, you see in the white line there is a black line. Between in this complete white line there is a black line. So this is the bursa. This is the potential space. Okay, this is the potential space for intervention. This is the subacromial. Now it is coming much better. Subacromial subdeltoid bursa. Okay, I think no confusion. Everyone has seen, understood? Any confusion? Okay, I hope
No.
everyone has understood. Okay then. So this so two parts I have already shown. One is your subscapularis, one is supraspinatus. Now I show you infraspinatus muscle. Infraspinatus. Shit. Okay, so seeing we know that where is infraspinatus. It starts from the infrascapular infraspinous fossa, from the just below the spine of the scapula. It starts like that, and then it goes again to the greater tuberosity like that. Okay, and what we can do to see more of the tendon? So if we do earlier for seeing the subscapularis tendon, we are doing external rotation. Here to see the infraspinatus tendon, we will do the opposite, internal rotation. Okay, so here also you can see the infraspinatus tendon in a nice way. Here we have to increase the depth a bit, this area. So more actually. So see, this is the supraspinatus area. This is the spine of the scapula. So you can see only bone only and nothing else. Now I am coming below the spinous process. So we are now in the below the spine the spine of the scapula. So this is the long axis. Left side of your screen is medial side. Left side of your screen is medial side, and right side of your screen is your lateral side. So what we are seeing here, two layers again we are seeing. So first layer is deltoid, second layer is your infraspinatus. Here also you can see very nicely that there is a central tendon in the infraspinatus. There is a central tendon, and this central tendon is actually gradually becoming the whole tendon, and it is also a bird peak appearance and coming and joining with the greater tuberosity. Okay, I show you the whole muscle. So this is the muscle. Okay, ये करो तो freeze please. So this total thing is the infraspinatus. Infraspinatus. This is the central tendon. This is the central tendon. Okay, this is the infraspinatus. This is bony contour of the scapula. This is the scapula, bony contour. Okay, so here it is the medial side and it is the lateral side. When I go more laterally, I will be seeing the tendon formation. Means I am coming like this. So I will be seeing the tendon formation and bird peak appearance, which is coming gradually and joining to the greater tuberosity. Okay, so just see again, and then I will go for a dynamic examination. So already central tendon is getting formed and has joined with the greater tuberosity of the humerus. So if I want to see more of the tendon, he can go, he is already actually internally rotated. So if I go in the neutral position, then this tendon will become actually smaller. This tendon is then it is the tendon is smaller. Now if he is going to the internal rotation, then this tendon is becoming much bigger. Okay, so this is the whole tendon. So we cannot see the whole tendon together. We will see part by part. Okay, so and what we will see that whether it is a fibrous fibrillar structure and hyperechoic or not, and if there is any associated articular bony margin, there is any defect, any bony defect or not. Okay, just a minute. Okay, so there is any bony defect or not. So this is the infraspinatus tendon. Okay, so this is the infraspinatus tendon. Okay, so now one more thing. When we are seeing the infraspinatus tendon, we are seeing the bony contour below. So what we are seeing? এত ডিস্টার্ব কেন দিচ্ছ? ক্লাস চলছে। Sorry, I forgot to mute the mobile. Anyway, so okay, infraspinatus already I have shown. So now to what is below the infraspinatus muscle? So when muscle or tendon. So this is the glenohumeral joint area. Let's see the below the contour. So when we are I can increase the okay, so here you can see the round structure is nothing but the head of the humerus. Okay, round structure is nothing but the head of the humerus, and you can actually see that whether it is really head of the humerus or not by movement. So you can see that this is moving, and you can see the articular cartilage of a black line above the head of the humerus also. Please. Okay, so this is not, we are seeing the glenohumeral joint from the posterior side. Okay, so this is the glenoid, this is the glenoid, and this is the humerus, this is the humeral head. This is the glenoidal labrum, fibrocartilage. Okay, labrum. And here there is a structure you can see. So this is just black color you can see. So this is nothing but the articular cartilage. Okay, this is the articular cartilage. So just see that we are seeing the joint from the posterior side also. Should be okay. So while seeing infraspinatus, we always see the glenohumeral joint also, and we are seeing the both glenoid part and the humeral head part. Glenoidal labrum also we can see, and humerus, humeral head also we can see. So now there are two more important structures. Okay, so is there any confusion here? Any confusion or whatever I have shown you till now? Is there any confusion in these areas? So one more structure I am showing you. So that is called AC joint. So you see, this was the glenohumeral joint and this is the AC joint. So in AC joint, so this is the this one I can palpate also. As I told you, if you just start palpating the clavicle gradually, you will see that at some area the clavicle is ending and another bone is starting. So this is the acromioclavicular joint. Remember this is the acromioclavicular joint. Please. So medial side, left side is medial, which is clavicular end. Left side is medial side, which is here, it is the clavicular end, and this side is acromial end. Okay, so here what we can see that actually what we are seeing that whether these margins look normal or not, margin of the bone, there can be osteophytes. You can get some osteophytes also, you can get effusion also, so it is not there. And we can see the acromioclavicular membrane, acromioclavicular ligament also we can see. Mainly it is the dynamic examination. If there is, as I told you, it is the osteophyte you will see, and effusion you will see, and while movement you will see that if there is a change in the level. Okay, here this is the normal level for him. Whether with movement one goes down or one goes up, here also one goes down or one goes up or not, so that gives a idea that this joint is affected, okay, or damaged joint. So just how do we see the how do we see the movement? Here you see the both the bony level is at the same level, bony margin. Now I will tell him to touch to his opposite shoulder, and I will keep the probe like this. So he has touched his opposite shoulder, and you will see the bone remains in the same level. So there is no instability. Okay, otherwise there can be a rupture of the acromioclavicular membrane, not membrane, ligament, acromioclavicular ligament, and there can be a instability of the joint. Okay, and there is no effusion, no osteophyte, so this is normal. Now another structure I show you, that is suprascapular nerve. So where is the suprascapular nerve? It is in the suprascapular fossa. So where is the supraspinatus fossa? So as I told you, first see the supraspinatus and then try to see the bony margin. So when you are seeing the bony margin, bony contour, then there, if there is a gap or not, try to find whether there is a gap or not. Actually, it is a bit difficult in him. So here, say this is the supraspinatus fossa. Okay, this is the supraspinatus fossa. But now I am trying to find a gap. So this part, अच्छा ये पर freeze को आगे देखिए. Okay. This is a gap between the bony margin. So here there is a vessel. Here there is a vessel. Sometimes it is very difficult to see, but since actually he is a muscular person, so this is like 4.5 centimeter. So it is very deep for him. So I mean, like for us to demonstrate, but then we will always see that this line could have been like this. So we will just tilt our probe, or we'll from one side to another side to see that there is a gap we can find or not. As soon as we find the gap, we know that this type of groove, one groove we will search, and we will see that whether there is any pulsating artery or not. So you will see the suprascapular artery and suprascapular nerve is always associated with that. I mean, just adjacent to that. Okay, shoot. Okay. So you see now this is a straight line. This is a straight line. There is no groove. There is no groove. Okay, but I can just tilt it like this or like this so that I can find the groove. Now I have already found the groove. So just in the middle of the screen, this is the groove, and artery, small artery is there. It is very focus. So you can see pulsatile artery. Just in the middle of the screen, I am trying to keep. No, please. You see the pulsatile artery, okay? So this is the suprascapular artery. If everyone has seen or not?
Yes, I see.
Yeah, it actually he is very. You see, this is the pulsatile artery, okay? So this is the suprascapular artery, and of course nerve is associated with that. Nerve is just adjacent to that, but every time seeing the nerve is not easy. Okay, so this is the whole supraspinatus fossa. This is the whole supraspinatus fossa. Okay, artery you can see nicely pulsating. Okay, then. So this is one suprascapular, mainly the nerve in the supraspinatus fossa, and another just structure I show you, that supraspinatus fossa is found also in the spinoglenoid notch. So where is the spinoglenoid notch? This is the spinoglenoid notch. You can see another pulsating artery. So same suprascapular artery is still there. Okay, please go. So I just tell you, under the infraspinatus, this is the infraspinatus muscle. Okay, this is the infraspinatus muscle. Now we have already seen the glenohumeral joint. So this is the glenoid, and this is the humeral head. This is the humeral head. We have humeral head. We have seen the labrum. This is the labrum. So now we are seeing just medial to that. Okay, just medial to that. So this is the medial to that. So this structure, this area is nothing but the spinoglenoid notch. Okay, just see the scapula bone. Today you just while seeing the recording, you see the scapular bone, you will understand which is the area. just medial to the glenoid, this is the spinoglenoid notch. Okay, so here we will search for a pulsatile artery, and then just if the patient is thin, we can see the nerve also, but in his case, we cannot see. Okay. I show you again. So as this is the infraspinatus muscle and this is the glenohumeral joint, if there is any confusion of glenohumeral joint, always make the patient to rotate, external rotation and internal rotation of the hand will tell you that whether there is any, humeral head is moving or not. So you can see the glenoidal labrum, the white part, and then the glenoid bone. And now I am going just medial to the glenoid, and you see the pulsating structure just in the middle. I have kept in the middle, and at a depth of 4 centimeter. So at a depth of 4 centimeter in the middle part, you can see something is pulsating. So this is the spinoglenoid notch, and just beside the artery, there must be the suprascapular nerve also. Actually, I can see the nerve now. Okay, just please. Okay. So this was pulsating. So this was artery, and actually this is the nerve. Okay, this is the nerve. Anyway, so this much only in demonstration. Anyone wants to see anything more? Tell me. And otherwise, I will show you the videos and pathology part mainly. Okay. Do. Okay. Okay. So I hope that this much you have understood, isn't it? Only some part. Okay. So just last part of the presentation, that already I have shown this thing: biceps tendon, rotator cuff tendons, SASD bursa. And of course, in rotator cuff tendons, teres minor I have not shown you because hardly any pathology comes clinically. Nobody comes with teres minor tendinitis. SASD bursa is there. I have shown glenohumeral joint and AC joint. I have shown. Okay. So this picture already I have shown you that this is the bicipital groove and biceps tendon. Medially, when you go, you see the subscapularis tendon, not the muscle. And more medially, under the coracoid process, actually, more medially when you go, you see the myotendinous junction. So this is lesser tuberosity, this is greater tuberosity. Lesser tuberosity means towards the medial side. So this is the biceps tendon in long axis. Now, why we want to see this biceps tendon in long axis and short axis? Because we want to understand the pathology. So here you see biceps tendinosis. There is some increase in the size of the tendon because of swelling, edema. And why if there is some edema and swelling is there, then what will happen? You can simply understand, simply think that water is black. So with white color, when you are adding some black part, so it will become blackish, means hypoechoic. So it has become a bit hypoechoic. So this is hypoechoic tendon. That's why biceps tendinosis. Here, of course, the complete tendon cannot be understood that much, but this same picture. So this is the hypoechoic biceps tendon. So this is called biceps tendinosis. So here also you see biceps tendinosis. This is a hypoechoic structure. This is a hypoechoic structure. So this is not homogeneous. This part can be normal, but not this part. Okay, not this part. Bicipital tendinitis acute finding means there acutely we find effusion around the tendon. Here you see in the long axis you can see some fluid. Of course, minimal amount of fluid, sometimes it is normal. In normal patient will not complain of anything, just incidentally you can find minimal amount of fluid, but not this much. So this is a effusion around the biceps tendon. Now this is also a effusion in the around the biceps tendon in short axis. Remember, bicipital tendinitis we will say when there is effusion in the around the biceps tendon, but there is no effusion in the joint. Otherwise, it will be the glenohumeral joint arthritis and effusion is just extended here. This is around the tendon only. Okay. So this is bicipital tendinitis chronic change. Why it is chronic? Because we can see there is some synovial hypertrophy and all. And so this synovial hypertrophy tells us that this is not acute, this is chronic. Because this synovial hypertrophy does not occur within a day, one day. So this is also around the biceps tendon. At least you can see that this is not normal. There are some this wool shaped or cloud shaped structure. So these structures called synovial hypertrophy and increased vascularity. This area will have increased vascularity. Biceps complete tear is also possible. In long axis, we cannot, in these areas, we cannot see any tendon. And here in short axis also, we may see that there is no tendon. Okay, there is no tendon. Here also this tendon is abnormal, you can understand. Actually, this is the tendon is rotated like this, This complete rupture and it comes, retracts. So biceps tendon in chronic tear, there is no tendon, it is fibrous tissue. There, it can be a biceps tendon subluxation also. Groove is here, but tendon you can see over the lesser tuberosity. Okay. Okay, this is not needed. So biceps tendon, how do we examine the biceps tendon if that is normal or not? So flexion and supination of the forearm, and you will, as an examiner, you will resist the flexion and supination of the forearm. So patient will, we will start the test. This is called Spitz test. You will start the test in a neutral position and patient will try to flex and supinate against your resistance. If there is a pain in the bicipital groove area, then you can diagnose this is a bicipital tendinitis. Subscapularis, already I have shown you the whole tendon in this way. Of course, this short axis I have not shown. So dynamic examination, I already told you. So when it is externally rotated, that means you are pulling some part of the tendon. Okay. Subscapularis tendon, as I told you, we will see that whether it looks normal or not. So here it is tendinosis and tear. So this is only a picture, but while in moving picture, you can see that this is a tear actually. This is a tear. And most of the time, tear can be of three types. Either it is articular side tear, or it is the bursal side tear, or intrasubstance tear. Here it looks that it is intrasubstance tear, but bursal side tear is also there. And not bursal, articular side tear is also there. When there is articular side tear, most of the time there is a periosteal defect in the bony margin. In the bony margin, there is a defect you will find. Subscapularis tear looks like this. So this is a picture, so you may not be able to see. So subscapularis tear also can be complete tear. There is no muscle. There is the whole tendon. So you can see this is the biceps tendon. Then it must be the lesser tuberosity. And there has to be the whole tendon should be coming and joining in the lesser tuberosity. But there is no tendon and there is some fluid. Actually, there is also a bursa. Just today I told you that between the tendon and bone, there must be a bursa. So this bursa gets filled with water. Okay, effusion. Subscapularis can be calcified. This is a calcification of subscapularis tendon. Big calcification. Big calcification. This is a big calcification. Jarber's lift-off test, that is internal rotation and adduction of the shoulder. So this is the position. Patient will try to lift the hand, and you will give the resistance. So it gives more pain to the stretches the subscapularis tendon at the junction of in the insertion of the bone, and patient can get more pain. Okay. Supraspinatus tendon, I have already showed you. So this is the supraspinatus tendon. This is the myotendinous junction, supraspinatus tendon in short axis, long axis, and already I showed you greater tuberosity. This is the head, and this is the cartilage. Okay, supraspinatus tear can be like that. So here the articular defect is always there when there is a, most of the time it is there if tendon tear is articular side tear. Okay, here it is intrasubstance tear. Of course, these pictures are not of the same patient. So this is intrasubstance tear, this is articular side tear. Supraspinatus tear. So these are supraspinatus tears. Complete tear, there is no supraspinatus tendon. So this is the humeral head, neck, greater tuberosity. So you can understand this is the bird peak appearance. This from the left side to right side, there should be supraspinatus tendon, but there is no tendon. Instead of that, there is some fluid accumulation. So where from this fluid coming? This is the nothing but SASD bursa effusion. Supraspinatus tear complete. Supraspinatus also can have calcification. You can see there is a calcification inside the tendon. So supraspinatus tendon, there are multiple tests. So there are studies even that which test is better. So I will say one test is Hawkins test, one is drop arm test, and one is Neer test. These tests are better than others. Okay, so this is a Hawkins test. This is to find that whether the patient has impingement or not. It means supraspinatus tendinopathy, and there is impingement under the acromion or not, mainly the subacromial impingement. So you read about the test, how it is done. So this test is for subacromial impingement, and mainly it is related to supraspinous tendinopathy. Drop arm test, mainly the 30° to 60°. 30° to 90° is the painful, it is the arc of the supraspinatus. So this can happen that patient after this position, after attaining this position passively by the examiner, you can tell the patient to lower the arm slowly. If patient cannot control the movement, and suddenly hand drops, then it is the drop arm test positive. That means the supraspinatus tendon, whose main function is abduction, controlled abduction, or the strength during abduction. So that is not being performed, that is not being possible. So there is supraspinatus tendinopathy. Likewise, Neer test is also like the first test, Hawkins test, but here the impingement, this test is done when the hand is not flexed. I mean, elbow is not flexed in this way only. So this is also for impingement of the supraspinatus tendon. Isometric strength test, that is also done for supraspinatus tendon. SASD bursa, I told you that it is the black line within that white line. First identify the two muscle layers, layer 1 and layer 2. Then in between white line, that is the loose areolar tissue area. Then the white line, black line between this white line. Okay, so this is the, if there is a bursitis, there will be fluid collection. There is fluid collection. So this much fluid collection is abnormal, because today on the volunteer you have seen that it is very difficult to identify even. Calcific bursitis, here also calcification can occur. in the bursa area. You can see both the layers. This is one layer, this is two layer. Okay, layer 2. Between them, there is calcification. Pus filled bursa. So this is if there is, I mean, hydrogenically after intervention, if you inject some bacteria, then patient can come with pus. So here, glenohumeral joint or adhesive capsulitis. So it is more of a clinical diagnosis. You can use ultrasound for intervention, but for diagnosis purpose, hardly you get many I mean, many ultrasound picture that you can say that this is frozen shoulder, nothing like that. So in what happens, you can understand the whole capsule. Here there is no effusion. Maybe in the starting there was effusion, but when patient has developed adhesive capsulitis or frozen shoulder, then this capsule becomes frozen, or it shrinks. Capsule becomes shrunken. Okay, so what happens? Global loss of active and passive range of movement. Neither you can lift, you can abduct the arm, nor patient can abduct the arm. Not only abduct, adduct, flexion, extension, all type of movement is lost or reduced, and pain at end range in all direction, end range. So if you do full flexion or full extension, there will be pain. But which is the most affected movement? External rotation, which we did while seeing the subscapularis tendon. So that is the most affected movement when frozen shoulder is developing. Next comes passive abduction. So while we did the supraspinatus tendon, dynamic procedure movement, then this is the passive abduction. So this one also, this will be second affected. And then lastly, it is the medial internal rotation also gets affected. But mainly I will say it is the external rotation which gives you the diagnosis of frozen shoulder. Now comes AC joint. So this I have already shown you. AC joint test, clinical test is Pexino's test. Pexino's test is nothing but you just stress the joint. That's it. From behind it is the acromion, and from the front it is the clavicle. You stress the joint, patient is saying the localized pain, then it is the, for AC joint it is positive. Cross body adduction test or scarf test, it also ultimately the stressing the joint and patient says localized pain, then it is AC joint for AC joint positive AC joint arthropathy. So here AC joint arthritis, as I told you, there can be effusion. There is effusion and there can be osteophyte, irregular joint margin, not joint, but a bony surface, bony margin. So you can understand that these are osteophytes and irregular bony margin, and there is effusion. So it must be AC joint arthritis. There can be AC joint subluxation also, but of course, if there is subluxation and all, it is more of a orthopedic of orthopedic interest. But then you can diagnose while doing the Pexino's test, or just not Pexino's test, cross body movement. I mean, patient is touching with one hand the opposite shoulder, then you will see that there is a change of the depth of the bones. So that is called AC joint subluxation. So let us see some video sections. So this is, I am diagnosing. So here you see, I don't know if volume is there or not. Anyway, so here you see what I am seeing, supraspinatus. So here you see that there is articular bony margin. There is a break in the bony margin. Okay, so I will first suspect that if there is a tendinosis, supraspinous tendinosis in the articular side only. So you can see this black part, this is the supraspinous tendinosis. Okay, and this is the articular defect, and this is the articular side tendinosis, this black part. This area has some tendinosis. So this is the supraspinous tendinosis. Oh, It's already I have shown. Okay, so this is an intervention of supraspinatus. So this same patient, I am doing the intervention. I am going inside the tendon and injecting PRP. Okay. Okay, so this is the same patient we have done. Then comes bicipital tendinitis diagnosis. So here it is a very small video, just you see. So here, so what we can see here, just in the middle part, this is the biceps tendon. Okay, this was the bicipital groove and this is the biceps tendon. Here you can see the whole around the tendon there is fluid accumulation. This is a short axis, picture. Again you see left side is the medial side, so subscapularis tendon I can see in the lesser tuberosity in the medial side, and then you see the tendon and around that there is fluid. This is called owl's eye appearance. So this is the fluid accumulation in the bicep, just around the biceps tendon. So this is for bicipital tendinitis. Subacromial subdeltoid bursa injection. Okay, so here also you see. So here, as I told you, yeah, I have stopped. So this is the layer number 1. This is the layer number 2 muscles. So I understand that this is supraspinatus tendon and this is the white color, the loose areolar tissue. So this black line must be my target. And remember, if you are inside the bursa, you will inject at one place, the fluid will move to other place. But if you are inside a muscle, then actually that part, muscle fibers will be separated and fluid will remain in that part only. So that we don't want. Many times I have seen many YouTube videos also that many people are not giving in the right bursal layer. They are coming either in the lower muscle fibers of the deltoid or upper muscle fibers of the supraspinatus. They're not muscle fiber, tendinous fibers of the supraspinatus. Again, you see. So it is coming from lateral side, okay? Lateral side to medial side. So see, as soon as you give fluid, it goes in another side. So this is called subacromial bursa injection. Okay. If there is any other thing. Anyway, I don't think any more thing is there. Okay. So this much is for tonight. Any question you have? Anyone has any question? Please ask. Otherwise, we will talk next day. Any question? Any confusion? Okay, then. Good night for today. Okay.
Good night.
Good night. Good night.
Thank you.
Welcome.